Hey everyone, this is Lakshit, and in this video I'll be talking about primary open angle glaucoma. So let's begin. So first of all, before talking about primary open angle glaucoma, let me talk about what is open angle glaucoma. See, as much as it made sense for us from second year, if this is my eyeball, pardon my drawing, if this is my eyeball and this is the optic nerve, and if this is the iris which stands here, then in open angle glaucoma, basically the basic definition means that this angle between the iris and the cornea, if I draw it as iris and if this is the cornea, then this is not obliterated. This is open angle glaucoma. But there are two types of things. But how can we basically define open angle glaucoma? So the basic thing which we use in open angle glaucoma to diagnose or define it is that because such patients are asymptomatic also, you might not be able to see, you may even think that it is a normal patient, but yes, it is primary open angle glaucoma. So if the difference between the left eye and the right eye, the L and R stand here for left eye and the right eye, so if the difference between the left eye and the right eye, the IOP difference, intraocular pressure difference, is the diurnal variation between the left eye and the right eye is more than 8 millimeters of Hg mercury, then you can say the person suffers from primary open angle glaucoma. So this was open angle glaucoma. But what is primary open angle glaucoma? Mind it, these are two different terms. Open angle glaucoma and primary open angle glaucoma are not the same thing. Primary open angle glaucoma is a subset of open angle glaucoma. See, if I talk about the etiology, so on the basis of etiology, there are three causes. There can be a trabecular cause, T, there can be a pre-trabecular cause, or there can be a post-trabecular cause. First of all, let me explain trabecular. So this part here, let me use a different color. This part here, this is the trabecula. And if I zoom this out, then it's a net or a mesh kind of a thing from which the aqueous humor is being drained out, and this is how the IOP is maintained and regulated. So if the blockage is in front of the trabecula, which is preventing the aqueous humor from reaching the trabecula, then that is a pre-trabecular block. And then there is PT, which is not pre-trabecular but post-trabecular. So in a post-trabecular block, there is block in the episcleral veins that is preventing the drainage of aqueous humor, and then there's a trabecular block which is happening in the trabecula. My mesh is not right. There is some kind of dirt or some cells which are clogging the the open empty spaces of my mesh. So this is trabecular, this is pre-trabecular, and this is post-trabecular. So the pre-trabecular, there are some causes. I can write it down for you, like Fuchs. Just say the pronunciation properly, okay? Fuchs heterochromic iridocyclitis. Or there can be neovascular glaucoma, NG. And these are all different conditions which I will talk about in different videos. And then in the trabecular part, or the trabecular causes of primary open angle glaucoma, we have the PAOG, which we will study today. PAOG, primary open angle glaucoma. And in the post-trabecular causes, we have sickle cell anemia, because there is sickling of the RBCs and it forms a clot in the episcleral veins. So since the pressure is increased in the episcleral veins, let me draw here the episcleral veins which are outside. So since this pressure is increased, if I form a clot here, then it won't allow the aqueous humor to be drained out from the eye, and the aqueous humor will again start being collected inside the eye, and that will raise the IOP. So this is the etiological classification, or how you can understand that how this is happening. The most common is primary open angle glaucoma, which has many risk factors which we see. First of all is old age. Second, if you're a patient of diabetes or hypertension, so this can cause primary open angle glaucoma. We have not been able to understand what exactly destroys the patency of this trabecular meshwork. But in this primary open angle glaucoma, the meshwork is impaired, and that leads to the collection of aqueous humor in the eye, further raising the IOP. So this is the etiology. Now let's talk about the pathogenesis. What is actually happening here? Like I told you, there is blockage of the trabecular meshwork. So if there is blockage of TM, so this blockage of TM, this will lead to increased IOP, which we see. Though I will talk about one more type in this primary open angle glaucoma, is that some patients are normotensive. You mean if you check that eye, which is particularly which we think or we suspect that it is having glaucoma, then the person will be completely having a normal IOP, but he will have primary open angle glaucoma. So that is why I told you this definition, that this diurnal variation between the left and the right eye, the diurnal variation of IOP between the left and the right eye should be more than 8 millimeters of Hg. That is why this part which helps us crack the diagnosis. So increase in IOP, what does it lead to? There are two effects basically. See, there is a perfusion pressure of the blood vessels in the eye. So this is calculated by the blood pressure in those vessels and the IOP which is outside. Now you must be understanding it, this is common sense, that this IOP is compressing the blood vessels from the outside, and this BP, this is the pressure of the blood in the blood vessels. So something which decreases this BP, or if there is increase in the IOP, that will lead to reduced perfusion pressure, and further the vessels will not be able to supply the retina or the other structures, but the retina is most affected. So this perfusion pressure starts decreasing due to increased IOP, and that leads to the ischemia of the retina, especially in the optic nerve head. If this is my retina, and this is the optic disc situated nasally. I hope you understand nasal. It is close to the nose, temporal is farther away from the nose. And if this is my macula, the colors are not actual colors, don't assume them for the actual colors for retina. I'm just using this for illustration purposes. So if my retinal fibers of the optic nerve head start destroying, then slowly what happens is that my vision becomes starts getting deteriorated. And one more theory is, or that the thing that happens is that if first of all the IOP is increasing, then that starts blocking the exit of fibers from the lamina cribosa, the optic nerve fibers which are coming here. Let me just use this. If this is the eyeball, different color. If this is the eyeball, this is the posterior part of the eyeball, and this is the optic nerve which is exiting out, and this yellow represents the optic nerve fibers. So these are exiting out from the lamina cribosa. Lamina cribosa, if this is a bone, it is also a kind of mesh-like structure from which multiple fibers of optic nerve are exiting out. So this intraocular pressure, it starts compressing the exit of these fibers at lamina cribosa, and this, when this compression of the nerve fibers happen, then this interrupts the axoplasmic flow. See, if this is optic nerve, this is the optic nerve layer. If I take a longitudinal cross section, then let's mark it that at this is the plasma membrane. Then there will be cytoplasm, which stands for exoplasm in the nerves. So if the exoplasmic flow is interrupted, if there is blockage in the exoplasmic flow, which is causing this exoplasm to stay here, basically this is the exoplasm. So this exoplasmic flow, this this trapped exoplasm starts compressing the optic disc and further compressing the nerve fibers which are coming and exiting through there. So when this gradually this exoplasm will start compressing, and it will start spreading throughout all the nerve fibers or the optic disc around that. We will talk about that in the visual field changes. But this is what happens, and that leads to the damage of retinal nerve fibers. And ultimately these two things: one, there is loss of blood supply; second, there is compression. These are the two keywords you have to remember. This will lead to retinal cell ganglion death. Further leading to the loss of vision, which we see in these patients very commonly. So now you can extrapolate the symptoms. That first of all, the patient will complain that my visual acuity has decreased. Since there has been loss of vision, also the patient complains of a mild headache, which we see in these patients. Now, if there is loss of vision and headache, one more thing is that when there is increase in the IOP of the patient or the intraocular pressure, that compresses the ciliary body. If I go to my diagram back here, yes, if I use this color for representing the ciliary body which secretes aqueous humor, so the collected IOP starts compressing the ciliary body. And when the ciliary body is being compressed, which contains the ciliary muscles, then the ciliary muscles can't contract, and this leads to loss of accommodation in such patients. So you will see presbyopia in these patients. The near vision will be not that good, and they such patients they complain कि हमारे चश्मे का नंबर जो है बहुत ज़्यादा बदल रहा है, या फिर हमें पास का नहीं दिख रहा है. रेगुलरली होता क्या जा रहा है कि हमारे पास का जो विजन है, मतलब हम नियर का तो नहीं देख पा रहे, जो नियर विजन है वो धीरे धीरे बेकार होते जा रहा है. दिस इज वॉट हैपेंस, इट स्टार्ट्स डिटोरिएटिंग इन दिस पेशेंट एंड दे टेक दिस कंप्लेन, and usually we just mark it off as this is age related changes, this presbyopia, but actually you must suspect primary open angle glaucoma in these patients. It has a very high association. So this is the clinical features. And if I talk about the signs you see when we do fundoscopy in such patients, then what we see is that, for example, this is the optic disc and here is the optic cup. There are two parts in optic disc. First you have to understand the normal. So if this is the optic disc, I write this as optic cup. Then this outside here is the neuroretinal rim. And this optic disc and neuroretinal rim has a normal ratio in patients, in normal patients. But in primary open angle glaucoma, since the nerve fiber start dying, so this neuroretinal limb, focus here, starts thinning. ये जो न्यूरोरेटिनल रिम है ना, ये थिन होने लगता है. सो व्हेन दिस न्यूरोरेटिनल रिम स्टार्ट्स थिनिंग, then this optic curve and neuroretinal rim ratio, there might be some diameter of this and there might be some diameter of this. So this ratio, this starts increasing, and that becomes, when it becomes more than 0.5 mm, then this is a clear cut sign that the glaucomatous changes are occurring. And also there is one more thing. I should have used an image for this, but I will add it later in my video. That if these are the blood vessels which are exiting out, as you see, and this is my optic disc. So what we see is that normally blood vessels are exiting out, the central retinal artery. But if we zoom in here, if we see in fundoscopy, we see that the blood vessels are angulating very sharply, like a bayonet. Bayonet in guns, if you know something about guns, then usually earlier, or if you have read history, British used to make a bayonet in front of the gun, which was very sharp and very angulating kind of a structure to kill enemies very easily. So this here, if we see the blood vessels, we see that there is sharp angulations of blood vessel, which is called the bayoneting sign, the bayonet sign. And this this sign is also very visible, which starts happening. Then why is this bayoneting happening? See, my optic cup or my optic disc in all is thinning. ये तो रेशियो बढ़ ही रहा है, जैसे ऑप्टिक कप और ऑप्टिक डिस्क का, नॉट एनआरआर, द टोटल ऑप्टिक डिस्क के डायमीटर में ऑप्टिक कप जो है वो ज़्यादा अपरेंट होते जा रहा है, क्योंकि न्यूरोरेटिनल रिम जो है घट रहा है, एंड द ऑप्टिक कप पार्ट विच इज़ दिस इज इनलार्जिंग बट दिस इज थिनिंग. देयर आर टू थिंग्स साइमल्टेनियसली हैपनिंग. ये ऑप्टिक कप इनलार्ज हुए जा रहा है. क्यों हो जा रहा है? क्योंकि बार बार अट्रोफी होते जा रहा है. तो अट्रोफी हो रहा है तो ये बढ़ते जा रहा है, और ये न्यूरोरेटिनल रिम इसका जो डायमीटर है वो घटते जा रहा है, या इसका जो थिकनेस है, ये कम होते जा रहा है. सो पार्डन माई मिस्टेक, दिस ऑप्टिक कप एंड ऑप्टिक डिस्क रेशियो इज मोर देन 0.5 mm. This is what is happening. So when this optic cup is starting to thin out, as you know that the blood vessels exit out from there only, but as the optic cup starts thinning out, जैसे जैसे उसके जो थिकनेस है वो घटते चल जाती है, क्या होता है कि जो ब्लड वेसल्स का जो कोर्स है ना वो हमें एपरेंट होने लगता है, जो उनका एंगुलेटिंग कोर्स है वो हमें एपरेंटली दिखाई देने लगता है. सो दैट इज़ वाई वी से दैट ब्लड वेसल्स आर किंकिंग, और ऐसा लग रहा है कि बेयोनेट जैसा शार्प एंगुलेशन उनका आ रहा है. So that this is the rationale behind bayoneting sign. You people remember bayoneting sign, but now you will be able to remember it very easily. So this is the bayoneting sign, or from the bayonet. Let me write the correct spelling. Bayoneting sign of which is seen in primary open angle glaucoma. ये एक bayoneting sign हुआ. And also we see the nasalization of blood vessels. Now what is the nasalization of blood vessels? What happens is that normally the blood vessels exit centrally, वो centrally exit करते हैं यहाँ से. लेकिन होता क्या है ना कि जैसे जैसे अट्रोफी होना शुरू होता है न्यूरोरेटिनल लिम्ब का, ऐसा अपरेंट होता है, ऐसा हमें लगने लगता है कि द ब्लड वेसल्स आर शिफ्टेड नेजली. फॉर एग्जांपल, इफ दिस पार्ट ऑफ द न्यूरोरेटिनल लिम्ब दिस वैनिशेज एंड दिस बिकम्स समथिंग लाइक दिस, ये ऑप्टिक कप है बड़ा हुआ, तो आपको नहीं लगेगा, यू वोंट यू थिंक दैट द ब्लड वेसल्स आर अपियरिंग अ बिट नेजल, थोड़ा नेजल साइड पे शिफ्ट हो गया, बिकॉज ये अपरेंट है. ऐसा नहीं कि ब्लड वेसल सर उठा करके हमने उसे नेजल ही रख दिया, नहीं, ऐसा नहीं है. ये एक्चुअली बाहर थिनिंग हो जा रहा है, तो हो जा रहा है. तो बाहर के कंपैरिजन में हमें ऐसा क्या लग रहा है कि यार ब्लड वेसल्स तो शिफ्टेड है, बट एक्चुअली हमने उन्हें रख के शिफ्ट नहीं किया, इट इज़ अपरेंट, ऐसा लग रहा है कि नेजलाइजेशन हो गया. सो दैट इज़ द नेजलाइजेशन ऑफ ब्लड वेसल्स. दीज आर द साइंस विच वी सी in fundoscopy, and also these are the diagnostic features which can be used to diagnose a patient of primary open angle glaucoma. So I am ending this video. If you like this video, give a thumbs up, comment down the comment section, and please subscribe. And I will make a next video about the diagnosis of primary open angle glaucoma and the management, and how do we manage primary open angle glaucoma. I take my leave. Bye bye.